Disseminated histoplasmosis masquerading as hemophagocytic lymphohistiocytosis. Although disseminated histo in someone with HIV/AIDS is a well-known phenomenon, presentation without pulmonary symptoms is not very common. Disseminated histo without pulmonary symptoms and presenting as HLH is even less common. HLH is a rare condition, but an association between HIV and HLH exists. Furthermore, HLH has a similar pathophysiology to immune reconstitution inflammatory syndrome, also known as IRIS, making the diagnosis even more challenging in a patient with AIDS. So we present the case of a 61-year-old gentleman who had a new diagnosis of HIV/AIDS 3 days prior to presentation to the hospital. He was very encephalopathic and weak. He had cachexia. He had been having severe weight loss with nausea, vomiting, and diarrhea for months leading up to his diagnosis. However, within 1 to 2 days of his hospital presentation, he had a rapid decline in his mental status, so his family brought him to the hospital. Of note, at the hospital, his pulmonary exam was completely unremarkable, and he never complained of any pulmonary symptoms, and his family never reported him complaining of any pulmonary symptoms. He was quite septic with tachycardia, increased respiratory rate, and fever. His basic labs on admission showed leukopenia, anemia, and mild transaminitis. He also had hyponatremia. He got an LP, and his CSF analysis was negative for any sort of bacterial or viral pathogens. His head and his chest imaging were non-revealing. Despite the fact that he was on broad-spectrum antibiotics, he still remained very septic. His transaminitis worsened, and he did develop an AKI, and 1 week after admission he developed thrombocytopenia, and his anemia and leukopenia continued to worsen. There were a few schistocytes seen on his smear, and he was on prophylactic enoxaparin since admission, but his 4T score was just 4, so it was unlikely to be hit. His direct Coombs was positive, but his clinical picture and laboratory evidence just didn't support T2P or DIC. Interestingly, his urine histoplasmosis antigen finally resulted, and it was strongly positive. Even more interestingly, his ferritin was greater than 15,000. So this, in combination with the hypertriglyceridemia, his altered mental status, and his cytopenia, was very concerning for HLH. So we sent a soluble interleukin-2 receptor, also called an SCD25. His bone marrow biopsy was performed for a pathology and culture, which did not show any malignancy, but insufficient samples were taken. So the results of his SCD25 testing were negative, so it nearly ruled out HLH. Given his very strong positive histoplasmosis antigen, we started treatment with amphotericin B rather than dexamethasone or etoposide. Once the amphotericin B was started, his overall status significantly improved, and then he was safely transitioned to oral itraconazole, and he was discharged to a subacute rehab. Below, you can see the diagnostic criteria that must be fulfilled to meet a diagnosis of HLH. He had fever, he had hypertriglyceridemia, he had significant hyperferritinemia, and he had cytopenias. So he was very close to meeting that diagnosis. What really set it apart was the positive urine histoplasmosis and the negative elevated soluble IL-2 receptor, or that CD25 that we discussed. And then to the left, we just have a nice presentation of, a really basic presentation of the pathophysiology of HLH. So this case is really important because it highlights the phenotypical parallelism between these two rare and arduous diagnoses. One much more common than the other, but still it's not a super common diagnosis to have disseminated histoplasmosis, but it is fairly common in someone with HIV. What makes this phenotypical parallelism even more challenging is HIV is a very known trigger for HLH. But in the end, the clinical and the laboratory evidence can be explained by the severe sepsis secondary to his fungal invasion. And this case gives readers the opportunity to distinguish an infectious versus a malignant etiology of cytokine storm, especially when timing for correct diagnosis and treatment is critical.